My husband used to say that when we went out to places, when I first started doing what we call the work, he'd say, "Don't tell people what you do." And I go, "Okay." So I started saying, not to people that knew me, but strangers, I'd say, "Oh, well, I work in healthcare." And I started to say I was a dietitian. But I went out to an anniversary party, a birthday party actually, 50th birthday party. There was a mixture of friends. She was one of my nurses. And there was a mixture of all different people. And this man came up to me and he said, "Oh, I heard about what you do." And I go, "So what do I do?" He said, "Oh, I was talking to your husband. You do this forensic stuff and you know an FBI agent." And I go, "Yes." And, "Oh, what else did my husband tell you?" So he elaborated, and my husband had it pretty right about what I did. So we were going home. I said, "I guess it's okay. I don't have to say that I'm a dietitian anymore." And he just laughed because at first he was embarrassed a bit about what kind of work I did, and because it was so unusual. And then he became proud of me and my work. Because these patients are unique in that their needs intersect with the law and with the justice system, that they all have health needs, whether they're physical or psychological. And the forensic nurse who's trained in all those areas is able to not only provide best practice patient care, but also to assist the legal system and the law enforcement to accomplish their roles as well.
What do we want the patient to feel like when he or she comes into the emergency room having had this experience? What do we want the patient to feel like when he or she leaves the emergency department?
I was called into the hospital last night by triage at Surrey Memorial Hospital. They told me that there was a young patient that was requesting to see me. So when I walked into the room, she was sitting on the couch, curled up in a little ball, and she was leaning on the armrest of the couch. And she was like this, looking down. When I spoke to her, I wanted her to know that I would do what I could to make her feel safe in that room. I asked her, "Is there anything that you need to talk to me about right now medically? Are you medically okay?" And at that point, she said, "I don't think I am."
That's what forensic nursing is to listen to both the verbal and the unspoken about their violence, about their trauma, and about the crime that may have been committed.
As a forensic nurse, the medical side of that always has to be looked at first. She was bleeding quite heavily, and she had told me that she had found some small marbles inside of her vaginal area, and she didn't feel right. She was cramping and sore. She signed the consent, and we started the examination. She had not showered, so we flared her body in the dark, looking for blood, semen, anything that would fluoresce in the darkness. We documented physical injuries on her body. She had quite a bit of bruising up her arm, down her back. She sat up in the bed and was looking at what I was drawing and asking questions about it, and became a little bit more involved because it was her. It was her body, and she wanted it to be documented perfect.
If people are treated in a way that is with dignity, with respect, with looking at their choices, they will not go on to suffer the psychological and emotional trauma that we know happens after crimes, violence, and trauma.
We document every injury that we see, and then I proceed to do a vaginal examination at the end. We collect swabs. I also did something called a motility slide, and that's a little bit of the vaginal pool washings on a slide, and we look underneath the microscope. She was wanting me to see if there was any semen on the slide. We then process that, all our evidence. We cut the ends of our swabs, we put them back in the swab container, we label them with the patient's name, put them in the envelope, label the envelope. I don't normally see that much injury, and I think just seeing that and her crying on the bed when I was doing the examination and just her emotional distraughtness and the injury.
Whatever happens to her after, she'll remember you and your caring.
Yeah.
She might not remember all the good things, she won't remember all the bad things, but what she will remember is there was a nurse who changed my life that night because of the way she treated me.
When I was walking down the hall, she grabbed my hand and her chin was up. And she walked down that hall and she said, "Amy, you gave me control of my body back. I lost control of my body. I don't remember what happened to my body. You gave me that control back, and I thank you for being here tonight for me." And she hugged me.
Hey Heather, it's Bobby Joe with the coroner's office. I think what we're going to do is go ahead and move him over to MUSC, and we will do the autopsy over there as a forensic case due to his fall.
In my office in Charleston, South Carolina, I will get a call, I or one of my deputies, and somebody's on call 24 hours a day, 7 days a week. And whenever that call comes in, we're going to respond to the scene of the death. We're going to do, in conjunction with, but independently of, law enforcement's crime scene investigators. We're going to do our own examination, our own photographs, evidence collection, etc. The coroner is the person who, in essence, owns the body. And the body often is a very huge piece of the investigation and the primary piece of evidence.
You might think that when you do a case that you receive a person, you do the autopsy and should do that in a black box without actually having any knowledge of the circumstances surrounding the death. But in fact, we need a lot of information. We rely heavily, almost solely, on the coroners to be able to provide us with information surrounding the death. A number of them are the forensic nurses. They've had training in that and certification in that. With that experience, they bring to them a lot of the medical knowledge that's involved in death investigation.
We're educated in everything from growth and development to pharmaceutical issues. We're involved with grief and wound healing and anatomy and physiology and injury and on and on and on. And we're already steeped in dealing with families and people in times of stress.
They are the investigators. They are the ones that are finding out, who last saw the person, what were the circumstances that existed when they last saw the person, what was their medical history, and how that could all be related and be pertinent to the autopsy.
Because we're nurses, we don't just treat that evidence as a swab or a shell casing, but rather as an individual. And of course, part of that is that that individual has family.
When I come into a scene, I'll go and introduce myself to the officer, and then I'll ask, where's the family? And then I go directly to the family. And that comes from my nursing background, that I approach that family first, and oftentimes I'm the first person who's gone in and said, "I'm so sorry to have to meet you under these circumstances." They've been separated, they haven't been given any control. That's the gift that a nurse can bring to that scene immediately, is the ability to connect and to show them that someone actually cares about them as part of the process and their loss.
The hardest part of my job as a coroner isn't the sights I see and the smells I smell. It's the grief of the survivors.
Hello.
Hi, my name is Bobby Joe O'Neill, and I'm with the Charleston County Coroner's Office.
Right.
And I am so sorry I'm having to talk to you. I just wanted to touch base with you about the autopsy that you requested from Roper Hospital.
Right.
And then just wanted to get a little information from you about the fall that occurred.
Uh-huh.
Could you kind of tell me how he'd been doing?
He kept saying he was really tired. And I said, "Well, honey, you've been going too much. You need to rest." So we got home. We settled in. He said, "I think I'm going to go ahead and get my bath." Well, he went and got in the shower, and that's where he fell. And he just collapsed. He didn't slip or anything, he just collapsed. They put him in the ambulance and they took him to the hospital. And the doctor came out and talked to me and said, "Well, he's doing real good." He said, "But I'm going to have to watch him real close, and we're going to keep him on oxygen and keep him up here for right now." I said, "Okay." In 2 minutes, he died.
If we only look at death investigation as ending with the death of the individual itself and what caused the death and those kinds of things, we'll get part of the picture. But as nurses, I think what's important is how do we help the living piece of that relationship, if you would, continue in a way that helps them to grieve appropriately, to heal, to move on.
We're assessing her needs and what she's needing out of this. We're going to be, the plan now is to follow up with her again as the toxicology report results come in, as their microscopic results come in. If there's something other than what they saw grossly on autopsy, we're going to be letting them know. So we're going to be assessing again, planning again, implementing again, and it just continues to go full circle. It's just the nursing process over and over again.
And frequently I'm asked, what is the reward as a nurse? And I'm going, when I move these living people from this place where they don't want to live themselves to helping them in a healthy fashion move back into life, where they're ready to pick up the pieces and move forward, it's tremendously rewarding. And I think nurses are so equipped to do that very differently than non-nurses.
I appreciate you just taking the time to treat me like a person and not just a widow. I truly appreciate your compassion, and it meant more than I can express in this note. Thank you for the dignity that you have given my husband and throughout, and how you treated us throughout the process.
The more I do in this field, the more I'm convinced that there is so much we need to do in practice, but it needs to be based on evidence.
And this model wouldn't be the model it is today if it wasn't evidence-based.
This is just such an open area for people to be able, nurses in particular, to be able to come in and say, this is a research area that I think is interesting, that can impact not only the forensic investigation, but the outcomes of that, and then health sequelae afterwards.
That kind of research really gives us a firm grounding for our practice and makes us credible when we either go to court or you go to the high-level policy circles and you get people to pay attention to this issue, and we change laws and we change policies.
We had this horrendous store fire. It was a furniture store called the Sofa Superstore. And in the course of fighting the fire, we had 9 firefighters perish in the structure, which was the greatest loss of firefighters since 9/11, still is to my knowledge.
The very first person we came to, the first fireman, wasn't on that list, which is a very scary thing because they thought they were missing 8, but the very first one that we recovered, they're not recognizing as missing. So that says to us how many more are missing. Recount your men.
And we did become involved in the rewriting or updating of the firefighter autopsy protocol. It's a national protocol. It's been another way that I think being a nurse impacts a much bigger community.
Nothing's more important than human life. And that's the way this coroner's office approaches that. The way they look at their death investigation with all their training and that expertise, the way they're problem solving, professional, compassionate for the victims. And from that, we're able to make appropriate criminal charges or to find out, this is either a suicide, natural death, or even moving towards an assisted. I mean, we've had them all.
We wear a bit of every hat. We function frequently as public health nurses. We do a whole lot in the area of mental health nursing. We do a lot associated with trauma, pediatrics. We do an awful lot with children's deaths. Understanding those components are critical to how we not only investigate the case, but often deal with the survivors.
When you have cases with children where there is trauma, in my mind, those are actually easier cases when there's not, because you have something that you can say happened. Now, we may not be able to say who caused it. I mean, that's where the difficulty comes in, but you're able to say the child died from this. Whereas in lots of these situations, there's no physical findings whatsoever, and so the final determination really comes down to being able to interview really well, being able to do a doll reenactment, being able to review records and notice discrepancies, because it comes down to the investigation. The autopsy in those cases are really not helpful. First line of defense from a death investigator is that we get it right, that we've got it right on the death certificate, we classify it right, because if we don't, and other death investigators don't, and all the statistics are wrong, the death certificates are wrong, and the public health and epidemiology is wrong, then we're putting all of our funds and our effort into areas of which we don't need to put the prevention.
In the beginning, people thought we were crazy. why would you want to get involved in all of the darkness, all of the tragedy, all of the blackness that is out there, the violence, the people with the sad stories, and just devote your lives to caring for these people?
People just didn't know what to do with them. They didn't know about evidence collection. They didn't know about thorough documentation. There was not a lot of collaboration with the police. And the knowledge about medical legal issues was very gray and fuzzy.
The advocacy organizations will tell you that they were in business since the 60s, obviously, but they didn't partner with nurses. And it was this partnering with nurses and law enforcement that was revolutionary.
Something as simple as cause of death, something as simple as the identification of human bite marks, documentation, terminology is critical to social justice in a court of law. Through these experiences, I recognized the need for nurses to have this education, and it didn't exist. And so I wrote the first master's degree program in what I called forensic nursing and submitted it to the University of Texas. The first program was implemented in 1986.
I was notified and told that Texas was going to do an initiative for development of statewide curriculum for the care of the sexual assault patient, both adult and child. And I was one of the few across the country with the expertise in caring for all ages, and would I be interested? And I said, no, no. The people that were pursuing me for trauma care said, oh, why would you throw your life away like that? And it was in that moment that I knew that's what I needed to do. I was like, wow, why would someone think that caring for victims of violent crime would be throwing your life away? But that was the mentality of health, is that has to do with law enforcement. That is not a health care issue.
Forensic nursing in Jackson, Mississippi has had instant acceptance. It was the strangest thing. We went first to the largest university medical center. I prepared for weeks for my presentation. I had stacks of documents. I had stacks of research showing why this program was so important to establish a forensic nursing program. I set up a big meeting with heads of departments and chairs, and I got in and started my exciting sales presentation. 2 minutes into my great presentation, the chairman of the department stands up and says, we're going to do this, y'all take care of it, and he walked out. I was speechless. I was shocked. There was such a recognition already of such a desperate need for patients to receive care, compassionate care, effective care.
What really makes it unique is the person who's using those envelopes and swabs, and that's what forensic nurses do.
The whole area of forensic health sciences, the concept of a forensic nurse examiner, is really an expansion upon the sexual assault nurse. Sexual assault is one small component of what a forensic nurse examiner can do. From the crime scene investigator at the scene, to the experts at the hospital, to the experts in the morgue, and to all of the scientists in between, ultimately to court, every person matters. A forensic investigation is a multidisciplinary team effort.
For kids like that, it's easier to move through the exam as quickly as possible. And I know you wanted to slow down, make sure she was comfortable, and all of that, but given her age, she would not have become comfortable. A little 4-year-old girl presented to the emergency department, and she was brought in by Dad, and Dad said that he was sleeping, but that he thought that she fell on her bike, on the bike bar, and he noticed blood in her underpants, and so he brought her in. There's a difference between what a straddle injury looks like on a child's genitalia and what sexual abuse looks like. And so we will consult on all of those cases regardless of how they present. So Kim, one of our nurses, actually was on that day, and so she went in to see the little girl, Anna. When Kim looked at her using separation and traction, it was very clear there was a very large blood clot. There was nothing else to do but call a surgeon, and we would go into the OR with the surgery team, and so that is what Kim did. Once the child was under anesthesia, then we could get adequate images of the damage that happened. We could collect evidence also, hoping that if there was DNA there from a perpetrator that we would capture that. Mom came in eventually. She had been at work and was, you know, just trying to catch up on everything that had happened, and I think a little bit in shock.
Not every case that we sit down with the parents and show them the pictures, because it can be very traumatizing. It's traumatizing for medical professionals who do this. It can be traumatizing to see those graphic of images. Maybe later on I can sit down with you and show you her progression of injuries. Only if you want to, and you want to see those photographs, because they are pretty hard to look at, the first set of them from when she came in here.
I've been wanting to look at them.
I think that it would be helpful if you understood how serious her injury was when she came in. It is beneficial for us to have documented images of injury like this so that we can learn from the case and apply that knowledge to other cases we may have. Look how red she is from that follow-up in the exact same places.
When we try to talk about it, she blocks it out.
Yep.
She doesn't want to remember it.
Yep. It's a safety, it's a defense mechanism to protect her brain and her heart from a really horrible thing that she went through. So it could be she doesn't remember. It could be that somebody threatened her and has scared her.
And that's what we're thinking it was, that this person she knew, but this person probably told her, if you tell, then I'm going to hurt the ones that you love.
Yeah, that's very possible. We wanted them to see this wasn't just a little small tear or abrasion. This was serious, blunt force, penetrating trauma that left a lot of damage on their little girl. And that's why follow-up is important for her, because it's important that on some level she understands that even though she had to have surgery because of these injuries, her body is beautiful and perfect and going to be just fine.
It's several weeks later now. The little girl has not disclosed to us yet what happened to her, but she did have a forensic interview at the local child advocacy center. She has subsequently started telling Mom that Daddy hurt her, but not necessarily saying how.
And the nice thing about follow-up visits with this patient population is that with each visit, you're gaining their trust and you're building a bond with them. That maybe, it's probably not likely, but maybe the next visit will be the one that she feels safe enough and comfortable enough with you to tell her a little bit of what happened to her.
I think it's really apparent when we're training nurses that when they come out of the class and they start practicing on real life patients, that their focus seems to be very heavily weighted on what evidence am I collecting? Am I collecting the evidence properly? Am I packaging it properly? Making them step back away from the evidence and look at the global picture of the patient.
You can have a patient who has a flat affect, who's literally shaking and curled up in a ball. You can have somebody who's very angry and you know, verbally almost assaulting you because they're angry about the situation you're in.
It takes some work to rapport build with these patients when you see sometimes how traumatized they are.
It's very rare for a case to end in a successful prosecution, so that can't be your goal. Your goal has to be, this patient is leaving here more calm and in control than when they arrived here. We've given them some sense of control back in their life, and that is success to me.
I'm like, I kind of was blaming myself because I was like, oh, I shouldn't even went. I should have just stayed upstairs until I thought my cab was there, but...
Is it illegal for you to go out and have some drinks? No, it's not. Is there anything wrong with you standing out at night waiting for a cab? Is there anything? No, you weren't doing anything wrong. And nobody deserves to be sexually assaulted. Nobody, no matter what the situation. I think I told you before, I don't care if you were drunk, I don't care if you were high, I don't care what was going on, you didn't deserve to be sexually assaulted.
I just kind of thought they would be more judgmental than they are. You know, probably thought, well, how did this happen to her? She probably was doing something bad. You know, just very judgmental, and it wasn't like that at all.
There's just no way you're going to convince me that sexual assault is a logical consequence of anything.
Right.
It's not. It's not acceptable, and it's not a logical consequence.
Yeah.
The part that's very frustrating is the fact that so many young women and so many young people, I should say, view violence as almost a necessary thing that occurs.
I also found out that the majority of women who are killed in this country, whether they're African American, white, or whatever background, are killed by a partner or an ex-partner.
And to recognize, sort of for this social norms place, that violence is not the norm, and that's not supposed to be an expected kind of thing.
Forensic nurses understand that women become victims because they're targeted, because they're vulnerable. It's not their fault. They made a decision that many of us have made in the past, but we've been lucky. We haven't been targeted. We haven't been victimized.
We try not to ignore the men. We try not to just look for female patients, because there are men out there that are in abusive relationships. It may be that their female partner is abusive. It may be that their male partner is abusive. So we're trying to make sure that we're not overlooking special populations.
They also understand what the needs are of the victim of sexual assault or domestic violence that comes into the emergency room, and they're willing to give the patient the information they need so that they can make the choices they need and get the care that they deserve.
It was just, I was bleeding so much, I just was like, I'm sorry. I don't want to bleed.
Yeah, but we do these exams all the time when people are bleeding. It could be they're bleeding from their injury, or it could be that they're on their period. It's what we do, and it's what we do with every one of our patients, so it is normal for us. With that being said, we always keep it in mind that this is not a normal situation for you, and we get how vulnerable it is.
Then the rest of it's nuts and bolts. You know, which document do you use, which technique do you use, but the important thing is if you can capture what happens to that person's soul between the interaction between the nurse and the patient. That's what nursing is.
We have this patient over in Care Unit 3 that was assaulted by her husband. It sounds like it was a 2-day thing.
Okay.
Where the first day he tried to strangle her and was beating her. And then yesterday she says that he drug her by the truck. So she
attached her to the back of the truck? And
no, I guess he told her to get in. And so she was getting in, and he started the truck and driving and just took off. So, but she's got bruises everywhere.
Okay.
So.
And that hadn't been reported to
no.
law enforcement, so.
So I'm gonna call the police.
Okay.
And it happened in El Paso County. So, and then she asked if we could call Tessa.
Oh, okay.
Too.
Oh, okay, good.
So, because this isn't the first time. So,
good.
And she might be pregnant.
Oh, really?
Yeah.
Okay.
So we're going to go see this patient. She is in Care Unit 3, Bed 10, and we will go through our whole chart here that we have put together for IPV patients. Have her sign a consent. Hopefully she'll let us do photo documentation of her injuries, and we'll have her sign a consent for that. We'll do the body diagram, mapping out all of her injuries, measure all those, and record all those on there. Probably going to do a strangulation assessment. It sounds like there's something, I didn't hear quite everything that was going on, but it sounds like she has bruises on her neck and she was drugged by a truck. And going through the strangulation assessment, we'll just kind of go through all these steps, ask her all these questions, how she was strangled, 1 hand, 2 hands, if he used anything, if he did it multiple times, if she can kind of give us an estimate on about how long she thought it was, if she lost consciousness, all those types of things, how much pressure he used. And then we'll go through and look for any obvious injuries on her neck, or around her neck, and we'll also do looking in her eyes and her ears and stuff for petechiae or any injuries there. We'll document all that. Okay?
I got to go to an auto pedestrian. They transported the gentleman from MUSC from downtown.
Is he?
He's deceased.
Already pronounced?
Yes.
Or, okay, so you're going to head to the scene first, or the hospital?
The hospital.
All right.
Find out some more details, and then possibly go to the scene if there is a scene still.
We don't know anything about whether he's got ID on him, or don't know anything.
They have him. He has an ID on him. They gave me his name and everything and where he lives. So I might have to go find family.
All right. Very good. Thanks. I'll be around. Call me if you need me.
The disciplines of law enforcement and nursing are like a marriage. You bring these skills together, and it's one unique role where you can put everything together, all your training, education, knowledge, experience.
We know that forensic nurses are going to be incorporated into every community in the future. Violence is a healthcare issue, and forensic nurses are one way that we can address that within our healthcare system.
I took what Florence Nightingale thought about and applied it to our situation. We're never technicians. We do each and every act with intention, a healing intention. That's what nursing is.